my heartfelt thanks to Spring Physiotherapy Center and not to Hari for giving me this opportunity. I'm really honored to sit in front of you and talk. There have been very many occasions where I had been giving lectures, but this gives me a special feel for many reasons. I cannot really explain. I feel overwhelmed with this very presence here in this place with Hari. And last but not the least, I'm following, I should say, one of the best presentations I've seen of late. Very nice. It was hats off, Vasant sir. It was excellent. It was a very nice presentation. So there should always be like following a good presentation, you'll have a fairly not bad, but yeah, I'll be pushed. Okay, now my motivation level is being pushed up, but I don't know. So, and the greatest difference between the earlier presentation and now is that Vasantan was talking about something what he's doing now. Okay, after all these years of learning, his intellect, he has been trying to apply it on patient care, exercise part of it, implication of it. But now I am going to talk something in the past. Okay, he is talking what he is doing in present. Okay, and what he is going to do in future. But I am going to talk little about my past. Okay, my past. Don't think that I am going to talk something awkward regarding adhesive capsulators. Okay, so when I talk about my past, as far as adhesive capsulators is concerned, I think most of you will come into one part of the other when I talk about this. Needless to say, you may have a better experience or a better input for the same question what I am going to pose. You are always open to contradict, argue and fight and put forth your ideas. This is not to convey that this is the final end product, but it is something like I'm trying to narrate what I have experienced, and if you have any better ideas, I'm always open to take it up. Okay, there's nothing like this the final one. Yeah, having said that, just sit back and relax. So this character you will all enjoy. You know why? Because this genius has been depicting the worst part of the life in a lighter way. Okay, so Vasantan was talking something on a highest level possible, according to his intellect. Okay, but he was talking more on the positive side. Okay, this experience of mine is going to make some silly notings, awkward situations, okay, some embarrassing moments in front of the patients, in front of your boss, and what I learned from that. Way back, 25 years back, we never had people like Vasantan, Hari, XYZ, teachers. So these sort of teachers, what happens is, there is somebody to whip you at your back and say that what you're doing is wrong. We never had such one at that times. We never had textbooks, for example. We used to read books, Xerox copies of exercise therapy book. We never had original books. Now you have all the soft copies in your mobile. Okay, so that was that situation, and the situation has changed a lot. So never think the situation was the same that time. So the level of evidence is going to be below what is considered to be a level of evidence. Okay, so this is just an experience. This is nowhere I'm going to standardize or claim that what is to be the art of a level or what you have to deliver. I'm not going to talk about the pedigree of it. I'm just going to convey that. And of course, experience teaches you a lot. So that is what I'm going to share today, and I wish you will enjoy the presentation. Before starting my presentation, Hari, yeah. Before starting my presentation, I would like to acknowledge, okay, not to you, man. Acknowledge my presentation to whom, sometimes difficult situation gives you better outcome. Like what Vasantan was telling, you have an environment where you create a demand. Okay, so the supply is as good as your demand. So my position way back in 2000 was very precarious that I cannot put it in fragmented, but I was not allowed to handle things independently with freedom. That was my difficulty. That was a situation which I had to face, I had to come out. So thanks to those people who gave me that difficulty, this constrained atmosphere, where which I had to excel and fly out. So I cannot name them, but I can definitely say that that situation of difficulty and the constraint has brought me here. It's not easy, but you always have to pick up from the most difficult situation. Understand, if you are comfortable, then I'm very sure that you are not growing. You are not going to grow. You should have difficulty, you should undergo some sort of turmoils and negativity, so that for you, the situation will try to push you to come out. The way you swim out, the way you run out is going to be the real fight, and that's where your career is going to grow. So that's how it happened in my career way back in 2000. Situation was so bad that I had to take up a wholehearted approach where I had to pursue my post-graduation, and from there on I went for my doctorate. But this doctorate or post-graduation didn't mean anything, but of course it makes a lot of difference. Okay, having said that, way back in 1995, I hope you can understand who this person is. Okay, he was no man. He was not at all noticed, was not notable. Actually, this picture was along with Raj Kiran. He was the first person to give Vadivelu his first chance. Okay, he identified the talent of Vadivelu. Okay, that was a time where we saw my seniors, where I saw my seniors mobilizing the shoulder day in and day out, every day of the week, every week of the month, every month of the year. Okay, so எங்க பார்த்தாலும் யாரை பார்த்தாலும் ஒரு ஷோல்டர் கேஸ் வச்சிருப்பாங்க, டிபார்ட்மெண்ட்ல வச்சிருப்பாங்க, பிசியா வச்சிருப்பாங்க. we call that day private case. இப்போ என்ன சொல்றீங்கன்னு தெரியாது இருக்கு. Okay, we say that சாருக்கு 2 பிசி இருக்கு, அதுல 1 பிஏ ஷோல்டர். அப்படின்னா என்னன்னா ஒரு வருஷத்துக்கு வருமானம் கேரண்டி. we used to charge some 40-50 rupees per day, and that is going to, hey, don't laugh man, that is going to give us the entire month. So that has not changed. So we are very smart in seeing mappla adasi capsulitis ulla varanda valachi podu. Okay, so that used to be our psychology. So we understand the high potent area of orthopedic manual therapy is in adhesive capsulitis. So shoulder is to be the most wanted domain in physiotherapy practice as far as orthopedics is concerned. So that was the first instigating factor. We used to, my seniors used to work for some 30-40 minutes. Okay, imagine 30-40 minutes ஒருத்தட்ட passive mobilize பண்ணனும்னா, that's something great. And believe me, you cannot run the show without having a staff. So you should give promising results. So I was from a place where patients are very, very smart. If they see you are good, they keep it on their head. If they see that you are taking a ride on them, you had it. Okay, I am from Coimbatore. Okay, so you can understand. So that situation was not that easy. So there was a demand for shoulder. So that's how that periarthritis came into my mind. Of course, it was not that challenging. I understood there is something big in that. Okay, so that time, no, one fellow will say periarthritis, the other fellow will say frozen shoulder, the last one will say, like some intellect like Vasant will say, no sir, both are wrong, it's adhesive capsulitis. Then you have to keep quiet for all the three, because every person will have a reason for their nomenclature. But you cannot, those days were difficult to contradict or to defend your nomenclature. So we used to accept everything. Okay, alias. Okay, you put all this. If your tutor wants periarthritis, okay sir, adhesive capsulitis, frozen shoulder. So you satisfy your tutor because he is going to give you 25 marks of internal marks. So why you to break it? Who is going to break your head? So that was the time. But 95-2000, believe me, shoulder stiffness is going to be a big stuff. Whether it is primary, secondary, idiopathic, it is not at all to be mattered upon. Shoulder stiffness is a huge stuff on your head. So that is going to be, that's a big picture what we had when I finished my graduation in way back in 95, and I was practicing outside, and then I went to JIPMA. Shoulder was a big stuff in those times. What used to be a line of management? Picture is shown different. Anyway, fine, doesn't make any difference. So if you see, the majority of the portion we used to spend time with electrotherapy. Okay, patient comes and the physician will say short wave diathermy. You ask for the patient, நல்லா இருந்ததுங்களா, நல்லா இருந்தது, எவ்வளவு நேரம் வேணும், இன்னும் 10 நிமிஷம் வச்சிருந்தா நல்லா இருக்கும், ஒரு அரை மணி நேரம் வைங்க. Who is bothered? Okay, so the patient is happy, is lying, is being attended, something warm. I'm not contradicting the idea of diathermy, but that was our main motive. And if you see, the next order of priority was our pain relieving modalities. That time I think you people may not be aware of it. IFT was coming into limelight. And Hari, 2000 no, IFT was a big thing. Even if you ask some of the seniors, IFT la syllabus la illa panna vekka maten. Hospital வீட்டுக்கு போனா ரெண்டு பட்டி வச்சிருப்பாரு, இந்த பக்கம் ஒண்ணு இந்த பக்கம் ஒண்ணு. So they claim that okay, it was not taught to them, so they are not aware of it. That was the claim. Even now people used to say. So order of priority, you see, electromodalities, thermal, and followed by electrical. This is better. You know why? It works on pain control mechanism. What is that? Pain gate theory, postulated by what is this? Okay, Melzack and Wall. So all these things were having a strong background of prescribing in electromodality based on pain. Okay, so this was occupying really 75% of the intervention, and you could see exercises was very less. Okay, I could hardly remember what exercise we taught that time for periarthritis shoulder. The patient is so romba valikudhu, onnu pannadinga நாளைக்கு விட்டுக்கலாம், வாங்க வாங்க வாங்க, என்ன பண்ண ஒன்றும் பண்ணாதீங்க, சட்டை போட முடியலைங்க, அப்படியே வாங்க. See, that was the way of approach. We used to comfort them. No, we never used to push them. As he was pointing out, we have to some way give some cost, but we never did that. We never had an expectancy, neither the value. We just said, okay, comfort, comfort, comfort. So that used to be the priority. So the electrotherapy occupied the majority of the portion, and the exercise therapy had very less. Of course, others in that time also we had our physiatrists practicing acupuncture. He said, rather than all your diathermy and IFT, my IFT works, my acupuncture is best. We never used to contradict because he was our principal. We say yes sir. Okay. Other than that, you didn't have any other option that time. So that was our line of management way back in 95 and 2000. Then see that this used to be the everybody will get in their internship posting of his shoulder, adhesive capsulitis. Okay, what it is, nobody knows what it is. Okay, some problem with the shoulder where you can't move it. So you start treating the patient without knowing what it is, how it started, where it is going to lead you, how are you going to guide it, what is the mode of approach you have. You give whatever the patient asks. We had 6 cubicles in our department. First 2 will be diathermy, next 2 will be ultrasound, the other will be the hot packs. So the order will be first week 2 day diathermy, the following week will be the ultrasound, the last will be the hot packs. By the time naturally the patient would have, the natural symptom would have got eased out, or because of this treatment or because of the pharmacological intervention, the pain would have subsided. And the சார் எங்களை ரொம்ப கவனிச்சாருங்க, என்ன பண்ணாருங்க, ஒரு வாரம் இதுங்க, ஒரு வாரம் அதுங்க, ஒரு வாரம். So the month, at the end of the month, the patient is happy, you are happy. But it used to be a difficult scenario. Believe me, it is very difficult to define what adhesive capsulitis is all about. That is the difficulty of adhesive capsulitis. It is very difficult. I am very sure, I can challenge, I can bet here. I can bet even Hari for that grand matter. If I put a patient, 2 similar patients, I can bet it's very difficult to identify this is adhesive capsulitis and it is not adhesive capsulitis. It will require lot of work, at least 2 to 3 days of work in continuum to identify this fellow might fall under hypo and not hyper. It is a hypo condition where now it is more to be like a stiff shoulder rather than something else. Okay, so that is what the whole picture is all about, to identify, and this requires, I am telling you, it requires lots and lots of practice, hands-on practice, and not the hands-on practice in workshops. Okay, so what you get to see is the model and not the patient. So this is where those institutes where you have lots of patients coming to you, where you get to have a hands on that, you have a better outcome. That's why people coming from certain institutions, like, I don't want to name them, but you can really pick them up, say that, okay, this fellow will do good. Why I'm telling you, you need practice on the patient continuously. So it's very difficult for somebody to confidently say this patient is a stiff shoulder, sir. This is not a stiff shoulder, sir. Okay, so this requires little bit of practice. So this used to be our situation at that time. What happened after 2010? What I expect? நம்மால கொஞ்சம் கொஞ்சமா மெருகேற ஆரம்பிச்சிச்சு, மீசெல்லாம் நல்லா முளைக்க ஆரம்பிச்சு, மார்க்கெட் வந்து சான்ஸ் வந்து, ஓகே. ஸோ திஸ் ஃபெலோ ஸ்டார்டட் டு க்ரோ. எப்படின்னு பார்த்தீங்கன்னா தென் ஐ ஹவ் அண்டர்ஸ்டுட் இது எதனால வருதுங்கிறது கொஞ்சம் தெரிய ஆரம்பிச்சது. I got to see post-op conditions developing to shoulder stiffness, idiopathic shoulder. இப்போ நான் idiopathic-னு ரொம்ப casual-ஆ சொல்றேன். But that time, no, I could make out that this has happened without any real cause. Okay, this happened because of trauma. This happened because of surgery. அப்படிங்கிற எனக்கு பாகுபாடு பண்ணி தெரிய ஆரம்பிச்சது. That was a time where we start to identify the etiological part of the other capsulitis, and we start to identify the difference between pain and stiffness. Till then we had been having the picture of எப்படின்னா shoulder stiffness அப்படின்னு வந்தாலே only one thing is there, that is pain. Okay, we never bother about stiffness, but this was the time where I started to understand the difference between in other capsulitis, how pain and stiffness are going to play equal role, or either one of them can have a dominant role on the other. So that is when I started to understand. I know this logic of pattern, capsular pattern described by Syriacs was highly practiced way back from 80s, but I started to understand and practice only from 2000. I started applying it in terms of examination level, examining the capsular pattern. What is a capsular pattern? Restriction in a certain sequence. A capsule is a covering in the joint which has got its own tendency to restrict a range in any direction, in specific direction. For a capsule, it doesn't mean a specific direction or an axis, or it all has a purpose. But when a capsule shrinks, or when the capsule becomes more adherent to the subsequent tissues, subcutaneous tissues, it produces an effect on the arthrokinematics and the osteokinematics of that specific joint. So in terms of that, what I would like to tell you is, it gives a presentation, okay, and this presentation has a specific sequence in highest movement of external rotation restriction in varied degrees of abduction. That used to be the classical phase which I understood. Even now, if you ask me very clearly, sir, clearly puriyera mari and a capsular pattern solunga na, I will be putting myself in a precarious situation. Why? Because this was postulated by a practitioner way back in 80s. He did it based on his experience. He has followed it up from 500 patients, based on which he started to say a capsular pattern of hip, shoulder, knee, X, Y, Z. So this doesn't have any basic science to support it, but this was based on sheer experience. So in my experience, I would neither negate nor stand for it, but எனக்கு தெரிஞ்சதெல்லாம் abduction வர external rotation restriction இருக்கும். ரொம்ப சிவியரா எடுத்துக்கிட்டீங்கன்னா நியூட்ரல்லையே external rotation restriction இருக்கும். abductionல போக அது அதிகமாகும். Then you will immediately ask me smartly, sir, what about internal rotation? Internal rotation will always also be restricted, but it will not be physically made out until otherwise the patient puts it. For example, if it's going to be left hand, he cannot reach for his back hair, or if it's a female, he cannot reach for his fastening the stuffs, like things. So it all depends on the understanding part of it. So what I understood was varying degrees of abduction can reduce the intensity of external rotation, and that's what it explains about the orientation of the anterior capsule, which actually restricts the predominant of your glenohumeral ligaments, which has got the attachments from the glenoid process and to the humerus. That causes your predominant restriction of the shoulder movements, and that is going to have a huge functional impact on your day-to-day basis. So that is what is going to be. And this is when I was fascinated. I am telling you, those times somebody is doing a manual therapy, you will find crowd na avlo gumbal irukum. Okay, mobilization naale gumbal irukum, adile manipulation na chance kedaiya. And there were only very little persons who were talking about that. Okay, because it requires a lot of good knowledge on biomechanics. That is where all of us are boomed. Okay, so most of the orthopedic physiotherapists, they wanted themselves to be shifted to manual therapy techniques, because they thought that is the only horizon for them where they can explore the possibilities for orthopedic cure. Okay, so mobilization was the only thing. குதிரைக்கு லாடம் போட்ட மாதிரி இப்படியே தான். Okay, so I was looking for an opportunity. எங்கேயாவது ஏதாவது கிடைக்குமா, யாராவது சொல்லி கொடுக்க மாட்டாங்களா? So that was a time where, you know, there is a course like called as certification in orthopedic manual therapy, COMT. யார் முடிச்சிருக்கா சென்னையில? So that used to be our fascinating. எங்கேயா போனோம்? ஆஸ்திரேலியா போனோம். எவ்வளோ செலவும்? 4 லட்ச ரூபா செலவும். ஐயோ, நம்ம சம்பாதிக்கிறதே இவ்வளவுதான், நம்ம 4 லட்சத்தை. ஓகே, அவர் எப்பயாவது நம்ம ஊர் பக்கம் வந்து என்னைக்காவது வந்து ஒரு நாள் கிளாஸ் எடுத்து ஹேண்ட்ஸ் ஆன் சொல்லி கொடுத்தாருன்னா உட்காந்துருப்போம். Yeah, I'm not joking. It might sound jovial now, but that time it used to be a bumper lottery for us. Okay, so that's when I started learning this posterior glides for periarthritis shoulder. I'm very sure that none of you will stand for this, including the boss. You will not stand for this. That's when we started to learn the posterior glide, and that was a time where I pursued my post graduation. I, of course, உங்கள மாதிரி நான் பிபிடி முடிச்சோன்னே எம்பிடி பண்ணல. பிபிடி முடிச்சோன்னே நான் பண்ண ஒரே வேலை கல்யாணம் தான் பண்ணேன். அதுக்கப்புறம் தான் எம்பிடி ஒரு 7 வருஷம் கழிச்சு பண்ணேன். So after my MPT, was it so funny? I took it on the light side. So 2010, once I completed, my only goal was to do my COMT. Okay, பிஜி படிக்க வச்சதே வீட்டில் ரொம்ப அதிகம், அதில் வேறு COMT ஆசையை பாரு. So that used to be my because I felt manual therapy is the only way through for you to gain success in orthopedic practice. That's where you can do hell a lot of changes. So I went about so that's where பார்த்தா COMT கடைசியில் பார்த்தா ஒருத்தர் மட்டும் 15,000 ரூபாய்க்கு சொல்லிக் கொடுக்கறதுக்கு ரெடியாக இருந்தார். ஸோ யாரான்னு பார்க்கறச்ச ஒருத்தர் கிடைச்சாரு. அவரை பிடிச்சி போட்டு ஒரு கோர்ஸ் சென்னையிலே வந்து I used to come travel from every day from Pondicherry to Chennai, attend the whole day course, catch the train and go back. So I used to value that exercises. The techniques. So my expectancy was very high, and 15,000 was a very big amount for me that time. So I had to apply for a loan, and I paid it. Okay, and I came for the course and I learned it. And of course, the teacher was a very good teacher. He taught me lots and lots of techniques. He taught me a lot of techniques. He taught posterior glide, posterior inferior glide, anterior glide, all glides. He taught me everything. I was very happy. Okay, my life is முடிஞ்சதுடா, பாண்டிச்சேரியில பின்னி எடுத்துருவோம் நம்ம. So that used to be my நாளைக்கே வாடா 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 வாடா. So that used to be my energy levels. Now, okay, the கவுண்டமணிக்கு லாட்டரி வந்தா இந்த தெரு வாங்க போறேன், வேலை கேட்டு சொல்லுங்கிற மாதிரி. So that used to be my attitude. Okay, because I've learned all the techniques. Now if I tell the duration, you will identify the person. So no, he was a very good teacher, right? Very good teacher. காசு கேட்ட தோசை. Okay, so that's how it is. So he was a very good teacher. Even now I respect him for his abilities. But சொக்கோட சொல்லக்கூடாது, நான் தேடி போனா அவர் எனக்கு சொல்லி கொடுத்தாரு. So there is nothing wrong in that. But one thing I'll tell you, that is when I started to impress my patients. When I started getting adhesive capsulitis, rather than to teach them some exercises, rather than to give them electrical modality, I just showed them at I should say that was a magic. That was a magic. Whether my approach, whether my looks, whether my place, what influence on the patients, I don't know. That Vasant should tell me. Something influence on the patient, and that had produced a very good complaints on my patients. They started following me like ants, because they understood there was something in me. Whether it gave me or the confidence, or I'm not very sure, because I cannot claim that was happened. But this technique of mine, okay, gave me a breakthrough, so that these adhesive capsulitis patients started following me a little bit. So I started to understand how to catch them, not to treat them, how to catch them. Okay, so so I just started grabbing them with my hands. Okay, so that was when I started practicing. And the most commonest glides what I was doing and I am willing to do in future was posterior glide, sometimes posterior inferior glides. If you really challenge and if you really want to discuss or argue with me, I am ready to argue, but not now, but later. But how it helps, it really helps. How, I can tell you later. That is my experience. If you ask me the proof, I'm sorry, I don't have a proof. Whatever the evidence we have now is not up to date. It doesn't give you, it doesn't translate into clinical practice or predictions or whatever, but it really does help in my clinical practice as far as adhesive capsulitis is concerned. So this is when I started to explore the possibilities of mobilization and manipulation in adhesive capsulitis. Yes, so that's how it all went. I started to explore things. I started to identify. I started to understand what adhesive capsulitis is all about. And here, as the understanding begins, your line of management also varies. Once you start to understand, you explain better. And explanation comes, implementation also becomes better. So the understanding, the explanation, the implementation as a very vicious role, you could see the role of electrotherapy modalities started reducing little by little, and the impact of exercises have come. It could be passive or active, but part of exercises started to increase and the electrotherapy started to shrink. Of course, there were other fancy techniques, like I don't want to name them, you people are familiar with all those things. So they started to come in, which I was not much fascinated towards it. But at that time, we came to know that the people will come suddenly ask, so do you do that technique for me? I said, no, I cannot. They used to walk out. But for me, it didn't make any difference because I belong to a setup where we have enough and more of patients coming to me. So there was no real drive for me to learn those fancy techniques, which I was not really fascinated, to be very frank. So that was the way of line management. That's how I shifted towards it. Then 2010-20, really, that was my time where I started to polish my skills. Because that's when I'm telling you, this was taught to me way back in 96 by my lecturer Ravichandran. Okay, he was my tutor, such a good tutor. He was teaching irritability. Okay, but he didn't put the word irritability. What is irritability about?
Pain response after some exercise or.
Can you refine what is irritability is all about?
How easily pain can be, severity can be.
Something about the pain threshold you are talking.
Yes. When it is increased or when it is so obvious, the way it perceive and express is very different.
No, I mean to say in a clinical orthopedic setup in a practice, if you want to treat a joint, how would you elicit the irritability of a joint? How will you clinically examine, or how will you fragment it down to a micro level to understand that joint is irritable?
Signs of inflammation.
So that's a sign.
Irritability is a word defined by my plan, so you have to come from my plan.
But still it's in practice. It's still in practice that everybody should know. You can be a neurotherapist, you can be a cardiotherapist, but basically you need to know what a joint irritability is all about. Sorry? Yeah, good. How can you explain it? How would I elicit it? Chilapa.
If you ask me related to manual pain comes before stiffness, resistance, or during the resistance.
Yeah, something like that. Exactly. What's your name? Vignesh. Good. We had this ideology of P1 and R1. Okay, so that in our time we call P1 comes before R1. That's what you said. Pain comes before stiffness. But to elicit that in shoulder, you really require lots and lots of skill. Have you ever tried in shoulder? You can do it in a hinge joint, but not in a polyaxial joint. It's very, very difficult. Polyaxial joint, you touch, he will slap you because you are hardly holding the hand. Okay, your cheek is very close to the hand. Okay, you elicit a little bit. I got beatings. They have pinched me, they have hit me, punched me. Okay, so they have you see that irritability, the P1 was more than R1, so irritability. So this irritability that is a more an explainable, a technical term. But in terms of practice, eliciting the irritability will make a lot of impact on your exercise prescription as far as adhesive capsulitis is concerned. Believe me. Shoulder joint is very, very close to your axial skeleton. It's one of the proximal joints of the upper limb. And if there is something very sensitive, if it's very painful, you are very sure none of your exercise will work up until otherwise you understand the level of irritability. And I advocate this irritability level for shoulder at what point of time is concerned. I make it a point that I see to that I elicit the irritability level before prescribing the exercise. Okay, so that is very important in terms of adhesive cap. That I understood in these 10 years of after learning what is manual therapy is. Okay, of course we learn a lot of techniques, but we really don't understand a condition and apply a technique based on that condition and depending upon the level of severity. So that's when your clinical skill and experience comes into play. Okay, it's not just you learn everything, but how you put it in practice, fruitfully and to that specific condition. Okay, that requires a little bit of experience. So that's what I gained. Of course, it was too late for me, but never late than be never. So I just started picking up in this 10 years. I understood how to attend to that irritability, how to select the exercise, mode of exercises and put it in practice and bring a fruitful response from the patient. Okay, so that's where the patient comes back to you. And then I somehow, this was the time I got associated to Hari, right? 2010, after 2010, that's when. So every time அது நம்ம பிஜி முடிச்ச உடனே என்னன்னா ஒரு பெரிய அறிவாளி மாதிரி ஆயிடும் எம்பிடி. ஓகே, எங்க உடனே பயங்கர சயின்டிஸ்ட் மூலையெல்லாம் வேலை செய்யும், பார்க்கறதெல்லாம் புதுசா தெரியும், எதோ புதுசா கண்டுபிடிக்கிற மாதிரி இருக்கும், உடனே ஒரு பேப்பரை போடு. ஓகே, so that used to be your attitude. There's nothing wrong in that, yeah. Okay, you should be that level.
Exactly.
You should have that drive in you, no? You should not say MPT என்ன பண்ணி என்னத்த புண்ணியம் வரத்தன வரப்போகுது, எங்க பொண்ணு கிடைக்க போகுது, எங்க பையன் கிடைக்க போறான். It should not be that way. You should be having some sort of rush in you, no? That constant what hormone secretes for your what is that hormone? Dopamine. Come on. Okay, so the Vasantan hormone should be there for you all the time to push you and get things done. Okay, this drive was there after MPT. But what happens now, sometimes you get hooked to some personalities, you try to land up in some new idea and you won't convey to them, it gets boomed. So my association with Hari was such a good association, was such a good critic, and I was also open enough to accept the criticism whatever he has given. Many of the time I used to get some fancy ideas. I immediately pick up the call and start to talk. And I said, sir, summa answer is about the way sir phone. When I thought so much and I am trying to communicate, this fellow is saying nothing. But you need a critic. Understand, if you want to grow, you need a good critic. Okay, I was fortunate enough to have a good wife as your best critic in all phases of life, in all possible ways of living, and in your career you have a and the second thing is having this critic in your career really shapes your career in the best possible way. It sometimes demotivates you, puts you down, but nevertheless you are on the right track. You are not misleaded, you are not going astray, you are going on the right track. You are definite for some good fruit. Okay, as long as your notions are noble. Okay, கடமை கண்ணியம் கட்டுப்பாடு இதெல்லாம் இருக்கிற வரைக்கும் நீங்க கெட்டு போக மாட்டீங்க. Okay, so have some noble thoughts, have some young fresh ideas, try to implement, get the best critic and start implementing it. But of course you should be open enough to take up the criticism at any point of time. So that was my way back 2010 to 20. And here you see exercises dominated my approach. And if you see, there is a small column of orange pie here, that was my patient education. Suddenly I understood spending time with patients before attending to them made a lot of difference in their follow-up, in their expression, in their understanding, in their compliance. Everything mattered. In adhesive capsulitis, compliance is a big question mark. Okay, in 2010, not 2010, way before 2000 to 2010, we did a study on adhesive capsulitis. First study in JIPMA, submitted by physiotherapists, because we come under a non-faculty group. No, we are not that respected. So when we went and presented a paper, no, we were looked down like this. Physiotherapist, yeah, but there were some people to encourage us. Come on, good. Give them a big hand. Start. And government institute, it was very difficult for us. So we postulated one study and we framed it, objectives, blah 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 blah, eligibility, exclusion, inclusion. That was a big thing that time. Okay, so that was a breakthrough in our approach. Of course, in the later part of it, we understood compliance part of it improved better once we spent time. The first visit the patient had come and seen you in the OPD. Give them an ear. My consultant used to say, "Enna pandriyo illiyo Mohan." Make the patient to sit and listen to them. If you start listening to them, you will start attending to them and they will start following you. So when the patient comes with pain, listen to them. So the patient education part of it is gradually increased. I understood there is something from the patient also who can contribute to the outcome part of it. So that was the major difference I identified along with the exercises, and naturally my choice of modality was getting constricted little lesser and lesser, and now I am sticking on to one modality. Can you tell what it is? What modality I prefer for adhesive capsulitis? Let it be my mom, my patient, sorry? That's it. As simple as it is. Moisture therapy, you will have it at your home, you can have it at my home, you can have it in road, you can have it in flight, airport, anywhere. It all requires is a hot water and a hot water bag. You don't require a 45,000 machine called as shortwave diathermy. Okay, hot packs can make such a good difference, but hot packs will have an impact only if you explain the patient what difference it is going to make you following before adopting an exercise regime, how it is going to make a difference, and you make him to understand without hot packs what it had costed him, with hot packs what it has got him. Okay, so if you make the patient understand, hot packs can have its own impact. So patient education had a major say in the later part of the last 20 years. So that was my thing, and of course before going to this, what I would like to tell is this is the period where I pursued my PhD. Of course I was more enthusiastic in doing my PhD in adhesive capsulitis, thinking that I am going to discover. What is the difference between invention and discovery?
Invention, you create something, discovery, you find something.
That time I didn't know what is the difference between these two. I had both the ambitions. I was equally, I wanted this and this. I'm going to find out some new thing. My name is going to come in there, that this, blah, blah, blah. I was enthusiastic. Perhaps I was a little on the over enthusiastic side, but that you need that push, and a rush should be there. And that's when I pursued my PhD, and that's when this others came into existence. Okay, we'll talk about that. What motivated me to adopt a new technique in adhesive capsulitis. But have you ever heard about the word eccentrics? Eccentrics. Can you tell me what difference does it do in orthopedic practice? I know you are very good in neurological disease, and I know I am not that good in that, so let me not get into that. Orthopedic practice, eccentric exercises, what is the impact? How do you put it in practice? Oh, you are a sports physio. You keep quiet. Other orthopedic practitioners?
Reduce the risk of injury.
Oh, again, sports physio. Then? Orthopedics. Okay. Good. Then?
Strengthening high load.
Good. Then?
tensile strength on.
Good. Then good. What you are telling is right. I'm not trying to defy your ideas, but what came to our mind was when we started our project in 2008, we understood that pain was a predominant factor where the patient limits his mobility and complaints drops to a drastically lower level, so you lose the patients. Okay, so we understood eccentric exercises could be a better option where you elicit a relaxation, okay, with a pain relief, gaining an extra range of motion in the painful range, so that we could capitalize on a function. So that used to be our new hypothesis. நான் சொன்னேன் இல்லையா புதுசா கண்டுபிடிக்கணும்ட்டு. So eccentric exercise was our invention. Okay, அது இன்னும் புக்ல தான் இருக்கு. அதுக்குள்ள 4 பேப்பர் வந்துருச்சு eccentric exerciseல. Shoulderலயே வந்துருச்சு. I think it was in 2013 a new paper came up, eccentric exercises, one our Indian author had given. It wasn't that great hit, but he had published it in a PubMed Index journal. That was a good theory which we thought of it. Everybody thinks, but only few people will bring it out in the way it has to be presented. That's where evidence-based medicine is all about. What you think, you will do, but you will not put it out. Okay. One thing is you will not know how to put it out. The other thing is you don't want others to learn. Okay. So suppose somebody says that you are not having evidence-based medicine, say that okay. Okay. So it is within you. It's good or bad, it's up to you. So that used to be my stage, and after this time my life has completely changed. Of course, I'm into neurosurgery. I don't get to see a lot of shoulder patients as I used to do earlier, but now I'm very clear on what. Can anybody tell me? I'm very clear of my present situation. Can you tell me what it is? Patient மேல கையே வைக்க கூடாது. நான் இப்ப ரொம்ப தெளிவா இருக்கேன். எதுல சொல்லுங்கப்பா? விக்ரம், விக்னேஷ். Sorry? That is a universal logic. Now,
know something about everything, then everything about one thing.
Something. Okay. Ipo I'm very clear. Okay. What I don't know. Okay. It took me 25 long years to understand. After trying to understand that I have not understood anything about it. Okay. That is what learning is all about. You think that you have understood everything, but you will start to understand what you are falling short of. What is that you are missing? Where are you supposed to go? Where are you going? Okay. This sort of understanding comes only in later part of your years. Okay. By the time you would have waved off some 20 years. Of course, you guys are very smart. You are not like me. You are understanding faster. Yeah, you have plenty of resources. That is enriching you. I think, Vasant, you agree with me. Nowadays, youngsters have got a lot of resources, unlike others. So, but now I understood that there are a lot of things I should learn about others encapsulators. Lot of things I should understand, identify, and learn more. I know what I don't know. Okay, so that is where I am now. So I am looking forward to those conditions, those interventions where the patient can manage themselves. The coping strategies, okay, self-appraisals, and self-help groups. You know, we have got WhatsApp group. You have WhatsApp groups? What all WhatsApp group you have? In your class, school, girlfriends, family, huh? Hey, cousins, yeah, cousins. WhatsApp group, what I have is Bell's palsy group. No, I have ACL group. What else, ma? Spinal cord injury group. These sort of groups I have. Okay, what will happen is one person will ask, sir, எப்போ வந்து உங்களை பார்க்க வரட்டும்? சார் செவ்வாய்க்கிழமை வேண்டாம் இருப்பாரு. Okay, so these sort of groups, now after seeing them, I see rather than you communicating to them, they come communicating themselves just for appointment. If it is going to be so much useful, understand சின்ன சின்ன விஷயங்கள்லாம் வந்து they can manage themselves. ஒருத்தன் கேட்பான், சார் எக்ஸசைஸ் செஞ்சப்புறம் வலி அதிகமாயிடுச்சு, பால் பாக்கெட் ஃப்ரிட்ஜில் இருந்து எடுத்து வைடா, அடுத்த சொல்லுவேன். ஓகே, ஸோ திஸ் சார்ட் ஆஃப் குரூப்ஸ், it is so fascinating for me that my group will manage themselves. In Corona it was very handy, very very handy. Okay, every weekend I used to have a good time with my WhatsApp group. Okay, அதுலயும் வந்து அந்த பெல்ஸ் பால்சி குரூப் தான் ரொம்ப காமெடியா இருக்கும். எக்ஸசைஸ் வேற வீடியோ எடுத்து போடுவாங்க. ஒருத்தன் இது இப்படி இல்ல அப்படி வீடியோ எடுத்து போடுவாங்க. வாட்ஸ்அப்பே வந்துருவேன் கண்டுபிடிச்சவன் பார்த்தான்னா. So it used to be so fascinating for me. So now I am thinking of doing something to other capsulitis patient where they can help themselves. See, ultimate aim in to help yourself. Okay, become more self-sufficient, independent. That is what is the goal of any cure is concerned. So that is what is more. I feel that's the ultimatum in other capsulitis intervention. So this is going to be. Now I am going to just narrate briefly introspection of pain. If you see this, my choice was diathermy and it slowly started shifting down. Moisture therapy started going up, IFT came down and exercises gradually increased. Okay, that was my introspection about the pain. And now tell me, adhesive capsulitis, will you give priority to range of motion? No. How many of you say yes?
Yes, but before that pain comes.
Now, will you concentrate on range of motion in adhesive capsulitis? In your assessment, will you make a note of degrees in your assessment chart? Will you work for the deficit range?
I think we can work, sir, but obviously.
No, you say yes or no.
No, sir. I think at the end comes.
No. Yes or no?
That has to be comprehensive, sir.
No, you say yes or no. Will you work on the range? Alagappan said half-heartedly no. Yes, good. I appreciate. Good. It's not that I'm supporting you. Say you should differ just because somebody. தெரியல இல்ல ரேஞ்ச் வந்து அப்டக்ஷன் வந்து 60 டிகிரி தான் இருக்கு, 120 பாக்கி இருக்கு. Will you work on that 70, 80, 90, 100, 110, 120 or இல்ல எனக்கு ரேஞ்ச் வேணாம்னு விட்டுருவீங்களா?
So even to meeting we have to work. Even to meeting we have to work.
Excellent. அது வந்து freezing phaseல acute phaseல அதிகமா இருக்கும். Fine. So range of motion was one thing I would like to highlight here. The next slide please. Yeah, this range of motion, if you see, manipulation, mobilization and active exercises. Adhesive capsulitis la, it is one of the area where all your manual therapy techniques comes handy. I feel strongly you should work on range of motion. Range of motion is an important arena in adhesive capsulitis, but you have to be very very careful in selecting the range which you want to work on and what extent of degree you really want to work on. For example, if the patient doesn't have abduction of 180 and the patient has got only 140, you should not be crazy enough to push him to 180. By doing so, you will definitely land up in more trouble where you will have a reduced abduction. This is just an example I am trying to give. So you should be very 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 careful in selection of patients, selection of range, and in the selection it has to have a purpose and a specific function pertaining to the individual's demand. So selecting the range is important and not selecting the full range of motion should not be the criteria. Here I would like to differ. In adhesive capsulitis, aiming at gaining range of motion should be an objective, but not gaining the full range of motion should be an objective. Tell me what are all the full range of motion which you require on a day-to-day scale in shoulder. Like for example, Vasantan sir was highlighting very often about eating function in case of stroke. Now tell me, what are the functions normally you require in shoulder which requires full range of motion? Not in sports. Sports is something different. Sorry?
Not every day, but
நீ எடுத்துக்கோ, விளையாடாத சமயத்துல எந்த ரேஞ்ச் ஆஃப் மோஷன் நீ ஃபுல்லா யூஸ் பண்ணுவ? Except for the left hand internal rotation in neutral or mild degrees of extension. Okay, internal rotation in extension is a functional range if it's your left hand and if you are an Indian. Okay, so all these conditions connected. So you should have some specific demand to be met out for you to work upon, focus upon and achieve that. So you should be very, very careful in selecting the range individual based on its function and demands. So if you would like to see my intervention on manipulation came down, but mobilization gradually increased. Active exercise of course plays a crucial role, which was not very little when I started my practice, but now it occupies on top, and I do mobilization, but that is not my primary aim. Understand, let it be manipulation or mobilization or whatever fancy techniques you take, you do MWM, whatever it is, whatever you know, it should be a part of your whole package and it should not be the package. Most of us do the mistake. Now we get carried away with techniques. That happened in 2000 to 2010. I was fancied with techniques, but later I understood techniques are techniques until otherwise it is being taken to the right proportion to be right individual for a right purpose. So it all depends on how you carry it further. So the mobilization part of course plays, but the judgment of the therapist plays a crucial role here. Of course, manipulation, I'm not a great follower of manipulation. I started very enthusiastically, but later I understood it doesn't have that big impact on other capsulitis. That with my little experience, that's my conclusion based on my experience. The next is the function. In 1995, 1999, 2000, we never used to bother about to ask, உங்களால முன்னாடி என்ன பண்ண முடிஞ்சது, இப்ப என்ன பண்ண முடியல, தெரபிக்கு வந்தப்பறம் என்ன பண்ண முடியுது. We never asked. Okay, we call it as ADL. Okay, ADL னு ஒரு காலம் இருக்கும். Our domain. So we used to have one column: eating, dressing, washing, bathing. Tick, 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 tick. Okay, okay. This used to be. And what is a contradictory thing here? You tell me. In a case of adhesive capsulitis, if you have stiffness, all these functions will be possible, except if it's your left hand, you cannot wash your back. அது ஒரு பெரிய விஷயம் ஒன்று வந்துடாது. ஸோ ஃபங்க்ஷனலாக ஷோல்டரில் இம்பாக்ட் பெருசாக உங்களுக்கு உண்டு பண்ணலை, பிகாஸ் உங்கள் டிமாண்டு இந்த லெவலில் இருக்கிறனால. ஓகே, ஸோ இட் டிடன்ட் ஹாவ் அ பிக் இம்பாக்ட் விச் வி நெவர் நோட்டிஸ். பட் லேட்டர் once you started to produce papers, I understood. I started to experience with SPADI, DASH, ACES. These sort of things came into my purview. எப்பவுமே தேவை இருக்கும்போது தான் தேடல் இருக்கும். அப்போ ஒரு தேவைக்காக தேடி போய் நான் பார்த்தது வந்து DASH. DASH is one thing which is user friendly, which has got a translated version of Tamil also. Okay, so தமிழ் வச்சு நம்ம ஈஸியா வந்து அதுல வந்து ஷார்ட் ஒன்று இருக்கு, ரெகுலர் ஒன்று இருக்கு. என்னப்பா தமிழ்ல வந்து DASH இருக்கு. அது வந்து இட் இஸ் நீங்க வந்து பர்மிஷன் வாங்கணும். ஓகே, கங்கா ஹாஸ்பிட்டல்ல பண்ணிருக்காங்க. அது பண்ணது வந்து நம்ம வாட் இஸ் த நேம், யா சிந்தியா மேடம் had done the translation and she has done it and it has been. இந்த மாதிரியான ரிசர்ச் ஒர்க்லாம் வரவேற்கத்தக்கது. ஓகே, இது வந்து ஒரு நார்மலா இருக்கிற குப்சாமி ராமசாமி எல்லாம் ஃபங்க்ஷனல் ஸ்கோர் பண்ணலாம். அந்த காலத்துல எல்லாம் everything will be in English. Difficulty in getting into the car, difficulty in fastening the shoes. நம்ம காலேஜ் வரும்போது தான் முத நாளே ஷூஸை பார்த்தேன். நான் போய் பேஷண்ட்டை போய் ஷூ போடுறது கஷ்டமா இருக்கான்னு கேட்க முடியுமோ? இதுல வந்து பேஷண்ட் ஃபீல்டு தெரபிஸ்ட் ஆர் அப்ஜெக்டிவா இருக்கும், சில சப்ஜெக்டிவா இருக்கும். ஸோ திஸ் சார்ட் ஆஃப் ஃபங்க்ஷனல் கொஸ்டினர்ஸ் in shoulder started to pour in by 2010, 15. It was done very recently. 16 la ஆச்சுன்னு நினைக்கிறேன் சார். DASH was translated, cross cultural adaptation. Of course, Hariyoda associate Thangamani sir he was involved in statistics. He completed it and now it is in practice. You can download it and idile web la irukku. Just go to permission and you can use it. Just use DASH. You can see how much progress you have made. And I am this now range of motion பார்க்கறனோ இல்லையோ அந்த ஆப்பை அனுப்பிச்சு விட்டுருவேன். ஃபில் அப் பண்ணி எனக்கு ஸ்கிரீன்ஷாட் அனுப்பிச்சிருங்க அப்படின்வேன். ஐ வில் அண்டர்ஸ்டாண்ட் வாட் இட் இஸ். இப்போ எனக்கு எவ்வளோ எக்ஸ்பீரியன்ஸ் இத்தனை வருஷம் பண்ணதுல என்ன இருக்குன்னா அந்த டேஷை வச்சு என்னென்ன ரேஞ்ச் ஆஃப் மோஷன் குறைஞ்சிருக்குன்னு ஓரளவு கணிக்க முடியும். நாட் எக்ஸாக்ட்லி. ஸோ that has given me all this time. The time has taught me how to understand and predict it. So this is about the introspection about the function as far as adhesive capsulate is all these 25 years. I had and சொன்ன இல்லையா சில காமெடி எல்லாம் நடந்தது அப்படின்னு சொல்லிட்டு. Okay, in 1998 there was a station master from Vilupuram. ரொம்ப இன்ட்ரெஸ்டிங்கான, used to be a very sincere man. He used to come with a big specs, old man, some 60-65, gross stiffness. You could have never imagined. ஷட்டை போடுறது இதுக்கு மேல அவரால் இழுக்க முடியாது, கையை இந்த பக்கம் இழுத்து இருக்கும், இந்த பக்கம் இப்படி இருக்கும். ஓகே, அவ்வளவு ஸ்டிஃபா இருக்கும் அவர் ஷோல்டர். கிட்ட போனா நான் தடிக்கும் அக்கில்ல, அவ்வளவு ஸ்டிஃபா வருவார். அவரை படுக்க வச்சு கால் ஒரு 2 பேர் பிடிச்சி கை ஒரு பக்கம் பிடிச்சிக்கிட்டு அடிப்போம் பாரு பம்பு. ஆனா அவர் வருவார் டெய்லி. He had so much of belief in Jipmar Hospital, not on Monakrishnan. Okay, don't think that he had belief on me. The place where I work, no, is a temple. So adha nambi nariya per varuvanga. So I used to do that. We pumped for about 6 months. Just imagine, or train pidichu varuvar 10 manikku முடிச்சிட்டு மனுஷன் பாவம் சாப்பிட்டு திரும்பி போயிடுவார். நல்ல வேளை இந்த 3 மாசத்துல கையை கால உடைக்காம அனுப்பிச்சோம் அவரை நாங்க. ஓகே, we were naive. நாங்களும் உடைக்கணும்ன்ற எண்ணம் இல்லை. we did mobilization, posterior glide, distraction எல்லாத்தையும் பண்ணோம். பட் 1 millimeter கூட இம்ப்ரூவ்மெண்டே இல்லை. What he was doing was, what is the classical sign of adhesive capsulitis? Have you seen that Butler's diagram? S sign. Can anybody demonstrate that to me? What is the classical sign for adhesive capsulitis? If you watch the patient from behind and you ask the patient to lift the shoulder, just with that look itself, you say this adhesive capsulitis. One prominent sign. Who's that artist who gives a very good picture in anatomy? What is his name? Netters. The Netters picture is there. Okay. The classical sign is இப்படி இருக்கும், கை இப்படி இருக்கும். Okay. This used to be the classical picture. Okay. You call this S sign. You can find it in what textbook? Almost in all the textbook, in orthopedic surgical textbook also that picture will be given. That is a classical S sign. The patient will be like this. Okay, rendu kai mela thukkunga appadina, okay, they will do this. This won't move. He was the first person whom we saw this S sign continuously for 3 months. No little change was there. None of our intervention helped him. Okay, so suddenly he vanished. We thought that he has improved. கடைசி நாள் வரைக்கும் ஒன்றும் வரல. ஆள் வரலன்னு இம்ப்ரூவ்மெண்ட் வந்துட்டா நாங்களும் விட்டுட்டோம். At about 2002-03, suddenly my boss called me. He called me and he appreciated. Mohan, what job you have done? Great, man. He has improved like anything. I stepped inside the OPD. My consultant was discussing and said, "Sir, Mohan sir, nalla irukingla?" He was lifting my hand. I was very happy. ஆமான்னு சொல்றதா இல்லைன்னு சொல்றதா அப்படியே நின்று அப்படியே பாஸை பார்க்குறேன், அவரை பார்க்குறேன். Hey Mohan, you have done a great job, man. You see, his shoulder is completely normal. Sir, நல்லா பார்த்தாருங்க சார், நல்லா போயிடுச்சுங்க சார். He is certifying me, thinking that I have done something. Testimony, the so-called testimony. I was in such an embarrassing position in my life. I couldn't say yes, no, smile, cry. All the expression was there in my face. Then the patient saw mobility was equal. வாங்க சார், பொண்ணு கல்யாணம் சார், பத்திரிக்கை வைக்கிறேன், வந்துருங்க வீட்டுக்கு. வர போப்பா, நீ சீக்கிரம் கிளம்பு. எனக்கு தெரியும் எதுக்கு பாஸ் கூப்பிட்டாருன்னு எனக்கு தெரியும். மை பாஸ் வாஸ் த பெஸ்ட் டீச்சர். ஹி வாஸ் an orthopedic surgeon. வெளில போனதுக்கு அப்புறம் மோகன் கம் சிட், உட்காருன்னு சொன்னாலே ஆப்பு ரெடின்னு அர்த்தம். சிட்டுன்னாரு, உட்காந்தாச்சு. விட்டாரு, விட்டு குட்டு அடிச்சாரு. அடிச்சுட்டு, யூ திங்க் தட் யூ ஹேவ் mobilized? Have you done this? The patient is thanking you and going. He is not thanking me, man. He is thanking you. You have done nothing. Do you accept it? Yes, sir. Then why he has to thank you? I don't know, sir. You call him, go call him and ask why he thanked you despite you have not done anything. That was the day I understood what self-limiting condition is all about. You people would have read it in papers. We have seen it literally in our own eyes. 2 வருஷம் கழிச்சு அவரா வந்தாரு, மூமெண்ட் ஃபுல்லா வந்துச்சுன்னாரு. அதுக்கப்புறம் அப்ப அப்போல்லாம் ஃபோன் நம்பர்லாம் கிடைக்காது இல்லையா. ஸோ வி வென்ட் டு த எம்ஆர்டி, கலெக்டட் த ஃபோன் நம்பர், ஐ கால் டெம் அப், வென்ட் ஆன். சார் நீங்கள் எங்கே போய் ட்ரீட்மெண்ட் எடுத்தீங்க? நேச்சுரல் கியூரியாசிட்டி இல்லையா, யூ ஹேவ் டு ஒர்க் ஆன் யுவர் வீக்னஸஸ். சார் இல்லை சார் நான் எங்கேயும் போகல சார், நீங்கள் சொல்லிக் கொடுத்த எக்ஸசைஸ் மட்டும் தான் சார் பண்ண வீட்டில், நல்லா போயிடுச்சு சார். ஸோ இட் வாஸ் த கான்ஃபிடன்ஸ் விச் ஹி ஹேட் இன்ஸ்டில்ட் ஆன் அஸ், exercise which he did, and the disease intensity had worked out. It was self-limiting. That's how he improved. Okay, so that was a wonderful example in our life what self-limiting is all about. So even if you work for 1 year, the patient improves. What does it mean? The condition has improved by itself. Okay, so it's not because of you. So time again has an impact on outcome of adhesive capsulitis. And this wonderful picture, cat likes milk. What happened to Tenali's cat? The minute you keep the liquid, the cat used to run away. So there used to be n number of patients who ran away from us. He was an exception. The trained master was exception. He used to run away from us. Patient used to run away because we were a bit aggressive. The orthopedic surgeon wanted us to be aggressive. We were aggressive. The patient was not compliant, did not accept it. The patient was not able to withstand our intervention. They just vanished away. So all our shoulder patients, 50% of them, they started to run away. That's when we understood the irritability part of adhesive capsulitis. That's where our exercise prescription plays a major role in exercise prescription. Okay, and last but not the least, this is when I got associated to Hari Om. I understood the outcome of the condition was not just going to be shoulder alone. It is going to be a background of systemic influence either by diabetes mellitus, let it be type 1 or type 2, thyroid diseases and other connective tissue disorders which can have a major say in the outcome of the disease. So as a physiotherapist, you need to understand and explain to the patient about the impact of the systemic disease on the outcome of the shoulder adhesive capsulitis. So you need to work not only on the shoulder. If the patient comes to you and for shoulder stiffness, I started understanding how to approach a systemic issue also. What are the risk factors involved in this patient with regards to his diabetic status or thyroid status. Diabetes, you have seen adhesive capsulitis more in males or females? Really? Is it your experience or your textbook knowledge? Really? How much of experience you have? Good. You have got a good knowledge about it. You see a lot of female patients coming with this adhesive capsulitis, and it is mostly associated with thyroid issues, and it is highly influenced with your hormonal status. That is one area where it is very sensitive, not much of work also being done. So that's how I understood about the systemic influence. The learning curve, the interesting part of my career, I was clueless in 1995 when I saw that shoulder. நான் பண்ணிட்டேன். Fine. When I started, I was completely clueless. I didn't know what to do. Okay. Then okay. So you could see this. This is how it started. Here I was completely clueless in 1995 when I saw shoulder adhesive capsulitis. Then I went on. Then there was one time where I started to understand. I was fairly confident that I'm going to do something. I was telling you, I finished my PG. I was bubbling with confidence. I said, I'm going to do something new. I was little confident. I started to understand what I wanted to know, what I didn't know. I started to understand. And later days, what happened was, I was in a stage where, thank you. This was a stage where I'm in now. I'm in this stage. You can understand the picture now. Okay. What is this picture depicts about? Sorry? Huh? No, what is this character? Yeah, Kaipulla. I didn't hear. Kaipulla, okay? I'm in this position where I understood very, very clearly that what I don't know. Okay? So that's when you start really understanding about a particular condition. That is where you get into depth. Okay? Something you were telling, no? You start to get into learn everything about something. Not something about everything. So that's the position where I'm really now. And I'm looking forward for a place where it's called as mastery. Mastery is the most toughest thing. Nobody can achieve that. It's a process in continuum where you continue to sustain your ability by sustaining your practice and putting it in practice again and again and again and again. What have you lost in these 2 years? What have you lost in these 2 years? Sorry? Human touch is lost, money lost, school is lost, everything is lost. Everything is lost. Sorry? Everything is lost. Once upon a time, college leave vada maataangala irundhathu. Tharaka maataangala irukku. No, I am not joking. Last week I went to my friend's house. இந்த பொண்ணு என்ன படிக்கிறா? 3rd year படிக்கிறாங்க. இந்த பொண்ணு முறைச்சிட்டே போச்சு. ஏன் முறைச்சிட்டே போறான்னு? அவ காலேஜ் ஜாயின் பண்ணதுல இருந்து லாக்டவுனுங்க. So that's the pain what they carry, na? And முக்கியமான thing என்னன்னா physiosக்கு வந்து, okay? And the human touch we have lost these 2 years. Arthroscopic surgeon has lost its arthroscopic skills. See, direct skill and arthroscopic skill varies. Arthroscopic skills requires lot of practice. We physiotherapists also have lost most of our skills in these 2 years. First, to get back the skill, you require at least 3 years to build. 3 years of continuum hard work. If you want to master an act, you have to work in continuum, and you keep learning, open to learning. Okay, that is where the mastery comes, and it doesn't stop or end with. And you could see my earlier presenter, how casual he was, how he kept his profile very low, despite he was very sounding knowledgeable and resourceful. That shows his earningness and willingness to learn more. He was keeping the place open, his thoughts open, and he was trying to attract more ideas. That's what his learning is all about. It doesn't stop with, it starts with. Mastery is about continuing to learn and accepting to know what you don't know. That's when you try to understand better. So, and this is what has given me a best platform. Most of the time I used to get good opportunities in good reputed places. They used to call me for lectures. Believe me, lectures shaped me the best I should tell you. When a call comes from Ortho 1, when you are going to speak in front of DVR, who is DVR? You should be really worth enough to go and stand in front of doctor. So that motivated me. In my career, teaching was the best thing which provided me a better platform to learn. Today I'm just sharing it whatever I have done. But for me to give a presentation, I need to do at least 3 to 4 full night of hard work. Okay, so if you want to really learn, if you want to really master, you want to understand something in depth, start to teach. Teaching is the best way to learn. And for me, I'm a backbencher, believe me. Somebody was talking about psychology in the morning. Okay, you know what's the best experience for me? What was the great motivating factor for me? My wife knows. I had an arrear. Okay, because if I don't clear, of course, if a break kadayadu, that time we had break. Second semester, if you don't clear psychology, you'll be 1 year back. Break kaida kudadenu vilundu padichen. Okay, so that was my motivation, sir, to clear that psychology paper, or else I would not have cleared it. Ipo irukra system la na 8th semester varaikum adai vechitu irundhen. So I was a backbencher, to be frank, but my career was shaped beautifully because of the teaching chances whatever I got, thanks to my friends, people who were good people around me who helped me to go give lectures. They instilled the confidence on me. I could deliver the best, the little knowledge whatever I had. That shaped my career. So if you are really keen on learning something, start going for presentations. Start with poster, paper, then end up with journal. Okay, journal should be the last thing. Now it is ulta, edutonna journal. That's where you are stuck. No, I'm not trying to demotivate you or demoralize you. Start with regular stuff. அடி வாங்கி clean hour. இப்போ பிரகாஷ் சார் பேப்பர் போடுறாருன்னா ஒரு நாள் வேலை கிடையாது. Okay, it's not one day job. He started like this, presentations. So start presenting papers, posters. How many of you have presented posters here? 2, 3 papers? அந்த அளவுக்குலாம் போட்டதுதான். Good, that's good. I'm seeing a lot of young faces nowadays coming up for papers. That's a good sign of growth for the profession as well. And insights இந்த விஷயத்துல இந்த 25 yearsல whatever I have learnt is shoulderல வந்து eccentrics plays a better role. Of course I don't have evidence, but my experience I can say eccentrics will definitely work for this patient. And nocturnal pain is one area which has not been worked out, Vasansan sir. I think in your place you can have that as a research question. Adhesive capsulitis and nocturnal pain is one area where it has not really worked in depth. There are very little few papers, but not thoroughly worked upon. Nocturnal pain என்னன்னு கேக்குறீங்களா? என்ன படம்னு கேக்குறியா? இந்த ஐடியா கொடுப்பான்ல அந்த படம். Okay, so nocturnal pain is one area where we saw நாங்க அதுக்காக வர்க் பண்ணலனாலும் the one thing which we understood that we are on the right track was our intervention gave the individual a better quality of sleep. Okay, நாங்க என்ன பண்ணுவோம் கேஷிட்ல MP ன்னு போட்டு 1 2 3 ன்னு போடுவோம். How many times you wake up in the night with pain ன்னு கேட்போம். சார் 2 வாட்டி 3 வாட்டி 4 வாட்டி. We used to mark as 4+. ஆமா ஒரு 15 நாள் கழிச்சு வருவோம் வந்து கேட்போம். பெனி வலி குறைஞ்சிருச்சாப்பா? சார் அப்படியே இருக்குங்க சார், கை தூக்க முடியல. அப்படியா தூங்குறியா? தூக்கம் நல்லா வருது. எத்தனை வாட்டி எந்திரிக்கிற? அப்பெல்லாம் ஒரு வாட்டி தான் எந்திரிக்கிறேன். That's a huge thing. The individual has started to respond to therapy means your quality of sleep will be there. Can you explain why? The classical sign of adhesive capsulitis stage 1 irritability. Acute phase. What is the predominant sign? Nocturnal pain. Sleeping on the side you'll have it even in rotator cuff tears. You should not mistake rotator cuff tears with adhesive. Adhesive capsulitis will be a sharp, stabbing, continuous pain. That is a nociceptive stimulus when you get out of inactivity. Okay, reduced activity. They call excitatory levels are low. You get that nociceptive input. So, out of our experience, the research question and proof what we have is nocturnal pain is the first one to respond for your exercise therapy intervention. And of course, CKC exercise, you all know, that was my yogic. I am a great fan of yoga, not for everything, but specific. Yogasana, I started prescribing. That was one of my PhD topic also. Not a very great stuff we came out, but we did it for a research purpose. It did give us some wonderful results. I can discuss with you later. Few of yogasanas gave a CKC type of exercises outcome. What is CKC exercise? Closed kinetic chain exercise. Those patients who are not compliant enough for open kinetic chain exercises responded better for closed kinetic chain exercises. So that was our insights. And sometimes we understood that pain centralization of pain. Adhesive capsulitis, you have pain for more than 6 months. What is chronic pain? Define chronic pain. Pain more than 3 months. So there is a centralization phenomena in adhesive capsulitis. We both tried few cases for mirror therapy. Few clicked, but few didn't click because our patients will not understand the worth of mirror therapy despite adequate explanations. Mirror therapy did give us a few good results for centralized pain, and we invented a shoulder goniometer. Ultimately it was a flop, okay, but we could fix it on the couch because we found keeping the goniometer, the stationary arm and the movement arm, our exercise therapy teacher is hold it properly, once we move the mobile arm, we'll lose the static arm. It used to be, I can bet upon you, you cannot do shoulder flexion, goniometer is very, very difficult. So we came up with an idea of shoulder goniometer. It was a reasonably successful, but later we thought that goniometer in shoulder itself is a waste. Okay, that was our understanding in the later part of our life. Because you could identify 90 degrees kara ipdi mukkureenga paathaale theriyada sengutha ninna 90 idukku or instrumenta. So that was our, that's how you grow up, no? One day you see something fascinating, the other day your fascinating thing itself becomes an ugly thing. So that's how you grow. Okay, so that was our insight. And take home message, I am supposed to talk this, but I've left it. What is the optimal functional recovery, recovery for adhesive capsulitis should look like? You should have a pain-free sleep and a functional ability being restored. Okay, if you get an acute adhesive capsulitis, you should, what the outcome should be, the priorities should be to get an adequate sleep followed by an optimal functional pain-free recovery. That should be your take-home message. I was just trying to narrate, traverse through my experience for you to have a better understanding, insight about what you should look upon, what you should observe on. If you feel that this lecture was not complete in the sense of knowledge sharing, I wish you could go through this paper. I think most of you have read this. Most of you have read this. This is from Joe's PT. They have done a consensus. They have taken up all the literatures. This was published way back in 2013.
Spoke about irritability and based on that.
Exactly. That's a paper where they try to highlight what is the importance of irritability in shoulder adhesive capsulitis, because that is one area where it was not looked. That was a gray area in shoulder. It really makes a lot of difference. So that was the paper which gave a lot of, it endorsed the exercise interventions more than anything. Patient education was prioritized. If you have time, just download this paper. It is freely available on internet. You can go through all the probable possibilities of evaluation, standard means of intervention, including evaluation and measurement of outcome. This is a very good paper, and they would have classified shoulder into hypo and hyper. Hyper, you have instabilities, rotator cuff injuries. Hypo, it is classically the adhesive capsulitis. In the adhesive capsulitis, they would have categorized as primary and secondary. And the primary, what all the factors should be done, how you should assess the irritability, and what are all the ways you should interfere. So that this paper gives a very good insight of it. If I am just going to talk about this alone today, it's not going to be that interesting. Of course, I just wanted to share my little knowledge here. Any questions?